you, ma'am. Thank you for the kind introduction, and thanks to Bhopal Menopause Society for having me. My wife is also a gynecologist. She's a fetal medicine specialist, but menopause and reproductive issues related to endocrine is area of my both my research interest as well as my clinical interest. This talk is sponsored by GSK, the makers of Eltroxin. So this is a standard disclaimer slide. So what I'm going to do in the next 20 to 30 minutes is going to talk to you about optimizing hypothyroid management across the ages, especially in the perimenopausal age group, because this area is specifically related with menopause. There are some slides which are going to be there, but I'll often go off script as I often do. And we'll be talking a lot about clinical pearls, practical tips which will be useful to you in your clinical practice, and some common mistakes that we often see in clinical practice. So I'll divide my talk into 4 sections. First section will talk about how hypothyroidism correlates across the ages and the prevalence of the same in women. The second part will talk about how it deals with reproductive issues. In the third part, we'll talk about how it deals with pregnancy. Even though this talk is related with menopause, pregnancy is an important area for all practicing gynecologists. And finally, we'll talk about optimizing the dose of levothyroxine, Eltroxin in women with hypothyroidism. Now, why is hypothyroidism very important for women? I think, most of the time, hypothyroidism, it being an autoimmune disease, the women are the one who are most likely to be affected by it. Not only that, hypothyroidism in itself has a lot of correlations with both the menstrual issues as well as with fertility issues. And finally, it's very important to understand that hypothyroidism has a very important link with pregnancy. It can lead to both adverse pregnancy outcomes as well as can lead to infertility and other issues as well. So hypothyroidism has a very important link with women, especially women of both reproductive age as well as perimenopausal age group. Now let's then talk about 2 terminologies which are very frequently being used, and let me just clear these concepts very eloquently as much as possible. So there is a term called overt hypothyroidism and there's a term called subclinical hypothyroidism. Now overt hypothyroidism is there are 2 ways of defining it. Let me tell you both the ways. First and foremost, overt hypothyroidism can be defined from a clinical context. So if you have a patient with clinical symptoms of hypothyroidism, and typically they have the TSH which is elevated and the free T3, free T4, or the total T3 to total T4 are low. So when you have high TSH with low T3, T4, that is when you say that the woman has overt hypothyroidism. And subclinical hypothyroidism is when you have the TSH elevated, but the T3, T4 are generally normal. That is what is defined as a subclinical hypothyroidism. So that's the classical definition of overt and subclinical hypothyroidism. The second way of, also important way of defining is that typically women with overt hypothyroidism, so when your T3, T4 is going to go low, that is when the TSH will be typically more than 20. So any women with TSH more than 20, sometimes we don't do the T3, T4. So if you have a woman with TSH more than 20, that is overt hypothyroidism unless proved otherwise. And typically, when you have women with TSH somewhere around 10, that's most likely to be subclinical hypothyroidism. Again, you'll of course do a T3, T4, but that's unless proved otherwise. Now, one important caveat, let me put this across. If the woman has a TSH of somewhere around, let's say 10 or 11, and the T3, T4 are low, that is a point of time where there should be some red flags. And these type of issues are typically seen when you have pituitary related issues, right? So when you have a central hypothyroidism, the T3, T4 is generally mildly elevated, whereas the TSH is mildly elevated, whereas the T3, T4 is low. And one classical condition which is often seen in women is Sheehan syndrome, especially women who have had a very bad obstetric history and often will have history of postpartum hemorrhage. They often develop Sheehan syndrome. Sheehan syndrome is actually very common in India and often misdiagnosed and missed in clinical practice. So I think these are some clinical pearls which we need to keep in mind. I'll just request the AV group, if you can stop the background music which is running constantly. So it's A little distracting for both me and the audience, I hope. I think it's from the hotel, but it needs to be stopped. Okay, then let's see how hypothyroidism really deals with reproductive issues, right? And why it happens and how it really happens. So, first and foremost, if you see this issue from the reproductive issue, what I'll see from two perspectives, rather three perspectives. One is how it deals with the pituitary. So how hypothyroidism really deals with the pituitary related issue. Second, we'll see how it deals with the ovaries. And third, how we'll deal with the endometrium in itself. So if you talk about the pituitary, typically, what happens is when you have hypothyroidism, when your TSH starts going up, that stimulates. So whenever you have hypothyroidism, not only does it stimulate the TSH production by the pituitary gland, but it also stimulates the TRH production by the hypothalamus. Now you'll ask me why this is important. This is important because when you have high TRH not only stimulates the TSH from the pituitary, but TRH also stimulates the prolactin, which is released by the pituitary gland. So often you'll find hypothyroid women, and be careful about this. If you do a prolactin in women with untreated hypothyroidism, you'll find the prolactin to be high. And all the consequences that you see with high prolactin are also translated to women with this type of issue. So for example, a high prolactin will lead to luteal phase defects in your women. So if your patient is planning for pregnancy, it can lead to luteal phase defect leading to early abortion. Secondly, again, a high prolactin will lead to menstrual irregularities, sometimes even amenorrhea or oligoamenorrhea, which is again commonly seen in this women. And sometimes in rare circumstances, it can also lead to galactorrhea, which is sometimes, though rare with hypothyroidism, that is something we can see in certain women with hypothyroidism. So these are things where, again, remember, at the pituitary axis, when you have hypothyroidism, you can have elevated prolactin, and which can lead to these clinical consequences. Now, if you look at the ovarian axis, and this is something which is very important for menopause-related issue, and take this as a very important clinical pearl. Women with hypothyroidism, especially when you have Hashimoto's, the autoimmune hypothyroidism, they tend to have early menopause. This has been proven in multiple studies across the ages. Very interestingly, this also happens when your women with hypothyroidism is well treated. It doesn't mean that, untreated or poorly treated or improperly treated women have early menopause. Even women who have been properly treated tend to have early menopause. Now, there are many theories for this. One of the theories is that women with, remember it's an autoimmune disease, and one dictum we have already been taught is that when you have one autoimmune disease, you tend to have others as well. So women with overt hypothyroidism and of an autoimmune nature, they tend to also have an element of primary ovarian insufficiency. So a lot of women with hypothyroidism, you can expect early menopause in some of these women, right? So sometimes you have these women coming in their late 30s, complaining of oligoamenorrhea, complaining of typical symptoms of perimenopausal situation. I would say, if they have a history of hypothyroidism, one important clinical diagnosis you have to rule out is early menopause, right? So that's something we have to keep in mind. Well, a good test would be to do an AMH, and you'll often find AMH to be lower in these women. And if they've not completed their pregnancy or if they're dealing with infertility, it's an important pearl that you have to keep in mind while dealing with the thing, right? Finally, if you talk about the endometrium, if you have untreated hypothyroidism, the endometrial receptivity is poor, and you are more likely to have improper implantation or failure of implantation when you have untreated hypothyroidism. And that's why you often see that hypothyroid women who have not been treated properly, if they become pregnant, there is a very high risk of them developing first trimester abortion because of improper implantation. Again, a lot of you deal with IVF as well, and you all know that again, when you're planning for implantation, it's very important that the thyroid should be optimized before you plan for your procedure, right? So this is how hypothyroidism deals with infertility and it deals with reproductive issues. Then let's go with one very important, again, a very important clinical pearl. How does it really deal with PCOS, right? Now, whenever I say a woman has PCOS, PCOS is a diagnosis of exclusion. I need to rule out conditions which are similar to PCOS, which can masquerade as PCOS. For example, one is hypothyroidism, and I'll talk about that. Also, you have other conditions like you have a pituitary tumor, right? You have a pituitary prolactin producing tumor, or prolactinoma. That can also, present similar to PCOS. If you have a non-functioning pituitary tumor, that can also, masquerade as PCOS. There are certain rarer conditions, like for example, your congenital adrenal hyperplasia, which can also have symptoms similar to PCOS. But then let's focus on hypothyroidism. So typically, PCOS, women with PCOS have two classical clinical features. One is oligoamenorrhea, and second is presence of hirsutism. Both of these, to some extent, are also seen with hypothyroidism, right? So we already know that hypothyroidism leads to oligoamenorrhea, but what we know is that, sometimes hirsutism is mistaken for hypertrichosis, and women with hypothyroidism, untreated, often have hypertrichosis. So they have increased hair growth across the body, and that again sometimes is mistaken for hirsutism, right? So it's important to note that whenever you are, thinking of PCOS, right, you have to understand that the first and very important condition you have to rule out in all women you are considering PCOS is hypothyroidism, because that is again a treatable and very easily treatable cause of, what is now thought to be PCOS, right? So they have a very intimate relationship, and whenever you are suspecting PCOS, even when you have PCO morphology on an ultrasound, my wife is like I said, a fetal medicine expert. She does a lot of gynec ultrasounds also. Lot of times, a lot of you do your own ultrasounds. You'll often find PCO morphology on an ultrasound. It's very important in all these women that you rule out hypothyroidism, because again, that's a very important clinical association. And one more clinical association, which is very, very important, and a very important clinical pearl which you need to be aware about, is that hypothyroidism, especially untreated hypothyroidism, is a very important cause of dysfunctional uterine bleed and severe menstrual bleeds, right? So a lot of the times I see women with anemia, right, with hypothyroidism, and I often ask them that, how are your menstrual cycles? And they'll often say that the bleeding is very severe. Even subclinical hypothyroidism can lead to severe menstrual bleeds. So again, correcting hypothyroidism often corrects the problem in a lot of these patients. And again, this is a very easily treatable cause of menstrual problems. And again, whenever you have any women with severe menstrual bleeds, remember, hypothyroidism in itself leads to severe bleeding, right? Whatever organ you talk about, right? And for women, of course, the menstrual bleeds are very, very important. Again, correction of hypothyroidism will do two things. In itself, will correct the severity of the menstrual bleed, which will correct, reduce the stop of flow of the excess blood which you're losing. At the same time, hypothyroidism will also correct the overall, the reticular cycle, which will improve anemia in itself, right? So again, anemia with hypothyroidism is very, very important, and correction of hypothyroidism often corrects anemia in many of these women, and that can be a very important clinical, right? Now, let's talk about pregnancy and hypothyroidism again. So this is a topic in itself, right? So if I can spend 1 hour talking about pregnancy and hypothyroidism, but let me keep it brief, and let me keep it what is current, right? So when I talk about pregnancy and hypothyroidism, I want you to focus on two aspects. One is the TSH level in itself, and second is the anti-TPO antibody. Both have, in association with each other and independently, a correlation with pregnancy, right? Now, let's first talk about TSH, right? So let's say you have a lady who is planning for pregnancy, right? Or who has history of infertility, or who has history of poor menstrual, poor obstetric history with recurrent first trimester abortions, right? So what would you do? Obviously, you'll do a thyroid function test, right? Or let's say I see a lot of gynecologists do a routine thyroid function test in the first trimester in a lot of these women. So how will you interpret the results, and how will you go about treating that condition, right? So the newer guidelines, on this is what used to be older. The newer thing which we have to follow is what we follow, the 2017 guidelines from American Thyroid Association, where they say that you have to have a trimester specific range which is defined for your local population, right? This is very important, because earlier we used to use these cutoffs of 2.533. Now they say that you have to follow the cutoff which is prevalent, the upper TSH value, which is prevalent in pregnant women in your area. Now, of course, you will say that, we don't have the data for every part of the country, right? We'll have different in India. India is a very heterogeneous country, right? So something in Guwahati may not be applicable to what is available in Ahmedabad, right? Or available in Bhopal. So every single area will have their own cutoffs. So we don't have that data available. So what should you do? So if you do not have data available, the ATA says that you should use the upper cutoff for first trimester as 4, not 2.5, okay? So having said that, so let's say you have a lady, and let me put this scenario across. So let's say you do a first trimester TSH in your pregnant lady, and you find that TSH is more than 10, there is no doubt about it, you are going to treat this woman, right? So any patient with TSH more than 10, you are going to start Eltroxin and you are going to follow up this woman. But let's say you have a value between 4 to 10. Would you treat or would you not treat? Again, the answer is yes, right? So again, if you have a value more than 4, you should definitely consider treating this woman. The third level comes when you have TSH between 2.5 to 4. And this earlier we used to treat, but now the newer recommendation is that this is where you think whether you want to treat or not. So here the decision will be made by your anti-TPO antibody, right? So if you have a TSH between 2.5 to 4, and if you have anti-TPO antibody positive, then you should definitely consider treating this woman. But if the anti-TPO antibody is negative, then comes the critical part, right? Then comes the interesting part. Should you treat or should you not treat? Now, in this case, I'll say you should use your clinical judgment. So if a lady has a history of infertility, has a history of recurrent first trimester abortion, has poor AMH before they, in any previous records, in all these women, you should definitely consider treating. But if this is it's a primary gravida, young female, no prior history of abortions, anti-TPO is negative, you can consider just wait and watch to not treat, right? So this 2.5 to 4 is a critical decision point. Of course, less than 2.5 you are not going to treat, right? So again, that becomes very clear. So this 2.5 to 4 is a critical decision point. If anti-TPO is positive, definitely consider going towards treatment. And if the lady has history of recurrent first trimester abortion, definitely go towards treatment. But if it's not, you can consider just wait and watch and consider just following up this patient. Now, in these women, it's very important that you follow up on a monthly basis, especially in the initial 18 weeks of gestation, because again, the fetal, especially if the woman has overt hypothyroidism, if you have fetal, if you have, the fetus can also be affected, right? Because remember, the fetal thyroid function up till 18 weeks is dependent on the mother, and it's very, very important to consider this. Then let me go to the last part of my talk, and that is optimizing the dose of levothyroxine, optimizing the dose of your Eltroxin for women with both infertility as well as pregnancy, hypothyroidism, and hypothyroidism in general. Right? Now, let's take 3 scenarios, right? Let's take women in general, then we'll talk about women with infertility, and then we'll talk about women with pregnancy. So, women with, in general, right? Again, there are 2 scenarios. Either you have overt hypothyroidism or you have subclinical hypothyroidism. So, let's say a patient comes with overt hypothyroidism, frank mixed edema, right? TSH is 100, right? T3, T4 are low, clinical symptoms, classical textbook picture of hypothyroidism. What would be the dose of Eltroxin you'll give in this woman, right? Here, the answer is very clear. You give full therapeutic dose right at the first go. And the full therapeutic dose is 1.6 to 1.7 microgram per kg, okay? So, if you have a woman with classical overt hypothyroidism, don't wait to keep increasing the dose. You can directly start with full therapeutic dose of 1.6 to 1.7 microgram per kg. Let's take a second scenario where you have a subclinical hypothyroidism, and let's say the TSH is 9, right? Patient has prior history of recurrent first trimester abortion. Patient is planning for future pregnancy. What would be the dose in this situation, right? Again, there are 2 schools of thought. Either you can start with 1 microgram per kg.
Dr. Om, I think you are overshooting.
I'll just wrap it up, right, in couple of slides, right? So if you have, a value which is, so let's say patient is subclinical hypothyroidism, either you can start with 1 microgram per kg, or you can start with a slow dose of 25 microgram, and every 6 weeks or 2 months, you can reevaluate and increase the dose until you reach the TSH in the target range. And in this scenario, I like to keep the TSH close to 2.5 to 3 because the patient is planning for pregnancy. And finally, if you talk about pregnancy and hypothyroidism, again, if you have a pregnant woman with hypothyroidism, the decision point here is that if you have overt hypothyroidism, again, if you have any pregnant women with TSH more than 10, you can at that point of time directly start the full therapeutic dose. But if you are treating a subclinical hypothyroidism in this scenario, then in that case, you can consider giving a lower dose to start with. So if you have TSH between 2.5 to 5, you can start with a lower dose and then gradually up titrate depending on the clinical situation, right? So this is how you would deal with thing, right? Now, this is another important slide where you can consider. So you have again pregnancy, TSH more than 10, you can directly start with a higher dose. 2.5 to 10, you can start with 25 microgram and then up titrate as you go along, and try to keep your TSH less than 2.5 in first trimester and less than 3 in second and third trimester. Right, so I'll just summarize my talk with these points. Key important clinical points that you need to consider. First and foremost, pregnancy, hypothyroidism has an intimate relationship with women, right? So women, especially with menopause. Why with menopause? Because women with hypothyroidism, treated or untreated, are likely to have early menopause, right? There's a strong correlation between that. Secondly, what you have to understand is that reproductive systems, including at the level of pituitary, at the level of the endometrium, and at the level of ovary, all of them are related with hypothyroidism, and hypothyroidism treatment often improves all these clinical parameters. Finally, if you talk about dose optimization, any women with overt hypothyroidism, you have to consider full therapeutic dose in that scenario. But when you have subclinical hypothyroidism, at that point of time, you can consider slowly up-titrating the dose, start with the lower dose, and then gradually build up to reach the TSH for the target TSH depending on the clinical circumstance, right? So I'll end here. Thank you.
Thank you.
Thank you, ma'am.
Thank you, Dr. Om, for highlighting lots of important issues about the thyroid, which we are facing every day. We are all aware of it.
So wonderful talk, Dr. Om. Just a question, what TSH level would you like to keep in postmenopausal women?
Yeah, right.
What do you target should be the TSH level?
So for postmenopausal women, both the upper end and the lower end are an issue, right? So at the upper end, anywhere between less than 4 is fine, right? You don't have to try to target a stricter control. In fact, there are studies been shown that if you try to not, because as age advances, the TSH on its own increases over a period of time. So if you try to target a very stringent low TSH, that's not going to help the patient, right? So keeping a TSH close to 4 is fair enough, right? On the upper end. The lower end is what you have to be worried about, because in postmenopausal women, especially slightly older women, if you overtreat these women, you'll have 2 problems. One, they are already at risk of osteoporosis, you will worsen that, right? Because overcorrection of hypothyroidism is definitely linked with osteoporosis. Secondly, you increase the risk of cardiac issues, right? Especially arrhythmias, right? So again, overtreated women at the older age, postmenopausal women, overtreated will have higher risk of arrhythmia, right? So again, at this point of time, you will err towards giving a TSH on the slightly on the higher side, right? Instead of trying to over-suppress and over-treat this women.
Exactly. So under treatment is actually recommended.
Under treatment is better than over treatment for sure.
Over treatment. And if the